Glycated proteins and glycated albumin are powerful tools for detecting and monitoring diabetes, even in patients with different health conditions. But what exactly are they? And how did hemoglobin A1c, or HbA1c, become the gold standard marker for tracking diabetes? In this video, we'll break down everything you need to know about these markers, how they work, and why they're so crucial in managing diabetes effectively. So, before we dive in, make sure to subscribe and hit that like button, and let's get started. Glycated hemoglobin, or GHB, especially the HbA1c form, is a powerful tool for monitoring long-term glucose control in diabetic patients. Unlike daily glucose tests that can fluctuate, HbA1c provides a stable view of blood glucose levels over several weeks. Think of it as a long-term report card for glucose control. So, what exactly is HbA1c? In simple terms, it's a form of hemoglobin that's been glycated, meaning glucose has attached itself to the hemoglobin protein in the blood. This attachment happens naturally over time and forms a stable structure that can indicate average glucose levels over the past 8 to 12 weeks. This makes HbA1c a preferred marker for monitoring diabetes because it's unaffected by day-to-day changes in blood sugar. For patients and healthcare providers alike, it's easy to understand and has become widely known as the A1c test. But it's not only useful for monitoring. In 2009, an expert committee, backed by the American Diabetes Association and the World Health Organization, recommended using HbA1c to diagnose diabetes. A level of 6.5% or higher is now one of the benchmarks for a diabetes diagnosis. For those at high risk, levels between 5.7% and 6.4% can indicate a prediabetic state. By identifying and managing these levels early, healthcare providers can help patients take steps to delay or even prevent the onset of diabetes. Routine HbA1c tests are also essential for patients already diagnosed with diabetes. The Diabetes Control and Complications Trial, or DCCT, showed that higher HbA1c levels correlate with a greater risk of complications like retinopathy and nephropathy. In fact, each 1% reduction in HbA1c can lower the risk of microvascular disease by 37% and even reduce heart attack risk by 14%. With these benefits, it's no wonder that HbA1c testing is widely recommended, with most guidelines suggesting a target range of under 6.5% to 7% for diabetic patients. This simple number can help patients and doctors alike make informed decisions on treatment and lifestyle changes to maintain better long-term health. In recent years, HbA1c testing has become much more accessible. Today, thousands of labs across the country perform these tests regularly, allowing millions of people to manage their diabetes more effectively. When it comes to measuring glycated hemoglobins, specifically HbA1c, there's more than one way to get accurate results. In fact, there are over 150 different methods out there. Each one works by separating glycated hemoglobin from non-glycated hemoglobin, using either charge differences or structural differences. Among these methods, ion exchange chromatography and high-performance liquid chromatography, HPLC, are the most commonly used, especially in the United States. But other methods, like affinity chromatography and immunoassays, play important roles too. More recently, enzymatic assays and capillary electrophoresis have become commercially available for HbA1c measurement, giving even more options to labs around the world. For accurate results across all methods, most clinical labs report glycated hemoglobin as a percentage of total hemoglobin, with HbA1c being the preferred measure for consistency. To ensure reliable outcomes, the ADA recommends that labs use only NGSP-certified HbA1c methods, which align with DCCT reference standards. Let's start with ion exchange chromatography. This method separates hemoglobin types based on their charge using a special resin. Buffers are used to control how different types of hemoglobin are eluted, or separated, so that GHBs come out first, followed by other forms. To keep results consistent, temperature, pH, and ionic strength need to be carefully controlled. Next, we have high-performance liquid chromatography, or HPLC, an automated technique that's ideal for HbA1c measurement. HPLC is fast and requires just a small blood sample, about 5 microliters. The sample is separated using a buffer gradient, and detection occurs at specific wavelengths to ensure precision. Precise temperature regulation is also essential with HPLC to avoid any potential errors. HPLC is so reliable that it's become one of the most widely used methods. A 2014 CAP survey showed HPLC has very low variability, which is one reason it's a mainstay in large studies like the DCCT. Immunoassays are another valuable approach, using antibodies that specifically target HbA1c. These antibodies recognize a unique linkage in HbA1c, allowing them to ignore other forms of glycated hemoglobin in certain hemoglobin variants. This selectivity makes immunoassays highly reliable. Plus, they're available in compact analyzers suitable for smaller clinics. Another method is affinity chromatography, which separates glycated hemoglobin based on its ability to bind with boronic acid. This creates a stable complex, allowing for precise measurement of GHB. Affinity chromatography is particularly useful because it's temperature stable and less affected by hemoglobin variants, providing high precision with minimal interference. Capillary electrophoresis is an advanced method that separates hemoglobin types by their electrophoretic mobility in an alkaline buffer. This method is gaining popularity due to its high resolution and small sample requirements. Capillary electrophoresis detects HbA1c through absorption spectroscopy, and recent FDA approvals for automated systems make it an increasingly accessible choice for labs. Lastly, we have enzymatic assays, a newer method that measures HbA1c through a process called oxidative deglycation. This reaction releases a product that can be measured using a chromogen, providing an accurate HbA1c quantification. Enzymatic assays are fast and have been FDA approved for high-throughput use, making them ideal for busy labs. For accurate HbA1c testing, it's crucial to address labile, or unstable, glycated hemoglobin. This type of HbA1c can fluctuate with recent blood glucose levels, which can distort results meant to reflect longer-term glucose control. To remove this unstable HbA1c, labs can treat red blood cells with a saline or buffer solution at a pH between 5 and 6. Other methods, like dialysis or ultrafiltration, are also effective. Many column assay kits already include reagents to remove labile HbA1c, ensuring results focus on stable HbA1c levels. Consistency in HbA1c measurements is critical, but differences between GHB assays can cause variability in results. The Diabetes Control and Complications Trial, or DCCT, emphasized the importance of standardized HbA1c testing for accurate diabetes monitoring. To achieve this, the National Glycohemoglobin Standardization Program, NGSP, was established in the United States. The NGSP standardizes HbA1c values to align with DCCT study results, creating a consistent benchmark across different testing methods. On a global scale, the International Federation of Clinical Chemistry, IFCC, developed its own reference system, using highly specific methods like mass spectrometry and capillary electrophoresis. Although IFCC values run slightly lower than NGSP, both systems ensure that HbA1c results accurately reflect patient health outcomes and can be compared across studies like the DCCT and UKPDS. Proper sample handling is also essential for reliable HbA1c results. Venous blood collected with EDTA or oxalate is generally preferred, as these samples are stable for up to a week when stored at 4 degrees Celsius. For longer storage, samples can be frozen at -70 degrees Celsius, preserving them for over a year. However, if blood is collected with heparin, it should be analyzed within 2 days, as not all assay methods work well with this anticoagulant. When interpreting HbA1c results, labs report glycated hemoglobin as a percentage of total hemoglobin. For non-diabetic individuals, the reference range for HbA1c is generally between 4% and 6% using NGSP-certified methods. While HbA1c levels tend to increase slightly with age, they're usually not affected by acute illness. In patients with poorly controlled diabetes, HbA1c can exceed this reference range significantly. Levels above 15%, however, are uncommon and may indicate the presence of hemoglobin variants. For diabetic patients, clinical target values often differ from the standard reference range. The American Diabetes Association, ADA, generally recommends an HbA1c goal of under 7% for most patients, although some targets can be as low as 6.5% based on individual needs. Importantly, only NGSP-certified assays provide results that can accurately guide these treatment goals. To maintain optimal glucose control, patients who are meeting their HbA1c targets may only need testing every 6 months. However, for those aiming for tighter control, quarterly testing can be beneficial. In managing diabetes, tests for glycated serum proteins like fructosamine provide useful insights, especially for tracking short-term changes in blood glucose. Unlike HbA1c, which reflects blood sugar control over a few months, glycated serum proteins reflect the average glucose levels over a shorter period, just 2 to 3 weeks. This shorter window makes fructosamine testing ideal for situations where rapid glucose changes are expected, such as in gestational diabetes or therapy adjustments. Because glycated serum proteins aren't influenced by red blood cell lifespan, they can be helpful in conditions like hemolysis or after transfusions, where HbA1c might not be reliable. Fructosamine testing works by measuring glucose attached to serum proteins, mainly albumin. It's a faster and often less expensive alternative to HbA1c, but its role in routine diabetes management remains debated. Early versions of the test had limitations, with issues like interference from urates and lipids. Fortunately, second-generation assays have addressed many of these issues by adding uricase and detergents, making results more reliable. Automated and FDA-approved options, such as the NBT and fructosaminase assays, are available, and new techniques like enzymatic assays help reduce interference further. However, it's important to note that glycated serum protein tests aren't ideal for everyone. Patients with low albumin levels or fluctuating protein levels, such as those with nephrotic syndrome or liver disease, may not get accurate results. Other factors, like high levels of hemoglobin, bilirubin, or vitamin C, can also impact results. For these reasons, fructosamine testing isn't a substitute for HbA1c or glucose tolerance tests when diagnosing diabetes or gestational diabetes. For non-diabetic individuals, the reference range for fructosamine, using a colorimetric assay, is generally between 205 and 285 micromole per liter. When corrected for albumin, the range is slightly lower, and for enzymatic assays, the range typically falls between 151 and 300 micromole per liter. Another key glycated serum protein is glycated albumin. Albumin makes up about 60% of serum protein, accounting for more than 80% of glycated serum proteins. With multiple glycation sites, glycated albumin gives a picture of glucose control over a similar period to fructosamine, around 2 to 3 weeks. Glycated albumin assays are useful for evaluating recent glucose changes, but like fructosamine, more research is needed to fully understand its role in long-term diabetes management. Currently, glycated albumin's effectiveness in predicting complications remains uncertain. Several methods are available for measuring glycated albumin, including colorimetric assays, radioimmunoassay, RIA, enzyme-linked immunosorbent assay, ELISA, boronate affinity chromatography, HPLC, and mass spectrometry. Among these, the enzymatic method is the most widely used, involving the oxidation of glycated amino acids followed by albumin-specific reactions to produce measurable hydrogen peroxide. Reference intervals for glycated albumin vary depending on the method. For enzymatic assays, the typical range is 11.9% to 15.8%. While there's minimal variation within individuals, some differences exist between groups, with slightly higher values seen in Black individuals. Glycated albumin is particularly helpful in patients where HbA1c may be unreliable. For instance, in cases of poorly controlled diabetes, glycated albumin values can be up to 5 times higher. However, conditions that affect albumin metabolism, such as nephrotic syndrome, thyroid disease, or liver cirrhosis, can alter these values independently of blood glucose levels. One advantage of glycated albumin is its stability for long-term storage. Samples can be kept for extended periods, up to 23 years, at -70 degrees Celsius, preserving them for future analysis if needed. Kidney health is a major concern for people with diabetes, particularly when it comes to a condition called albuminuria, which refers to elevated levels of albumin in the urine. Albuminuria is a key marker of kidney damage, and tracking it is especially important in managing diabetes. Diabetes mellitus, especially type 1, significantly raises the risk of kidney damage. In fact, around 1/3 of people with type 1 diabetes develop end-stage renal disease, or ESRD. Type 2 diabetes also contributes to diabetic kidney disease. Though the individual risk is lower, type 2 diabetes is so common that it accounts for about 60% of diabetic nephropathy cases. Detecting diabetic nephropathy early is crucial, and this typically involves measuring urinary albumin excretion. Persistent high levels of albumin in the urine, known as proteinuria, often indicate that nephropathy is progressing. For example, an excretion rate above 200 micrograms per min or more than 300 milligrams over 24 hours is a strong indicator of advanced kidney disease. In the past, the term microalbuminuria was used to describe moderate increases in albumin excretion, between 20 and 200 micrograms per min. However, this term has fallen out of favor, as it implies a smaller form of albumin rather than an elevated excretion rate. Another effective measure is the albumin-to-creatinine ratio, or ACR, which can be done on a random urine sample instead of a timed collection. The ACR helps account for urine concentration variations, providing a more accurate marker of kidney health. Elevated albumin excretion rates, AER, don't just signal kidney issues, they're also strong indicators of broader microvascular disease. In fact, a persistent AER above 20 micrograms per min can increase the risk of kidney disease 20-fold for both type 1 and type 2 diabetes patients. Research has shown that increased albumin levels in the urine often precede diabetic nephropathy, ESRD, and even cardiovascular and total mortality. Fortunately, studies like the DCCT and UKPDS show that intensive diabetes management can significantly reduce the risk of albuminuria and subsequent nephropathy. By tightly controlling blood glucose, patients can lower their risk of developing these complications. For both diabetic and at-risk non-diabetic patients, controlling blood glucose and blood pressure is essential to slowing kidney decline. ACE inhibitors, a type of medication, are especially effective in preventing the progression of kidney disease and reducing cardiovascular complications. So, how is albuminuria measured? Although there's no strict consensus on the best method, adjusting for urine flow variations is crucial. The albumin-to-creatinine ratio, ACR, is often recommended. Several types of urine samples can be used, including a 24-hour collection, an overnight sample, a 1 to 2 hour timed collection, or an early morning sample. For the most reliable results, first morning void samples are preferred due to lower variability. Because biological variations in albumin levels are common, collecting 3 separate specimens on different days is usually recommended for an accurate assessment. Samples for albumin testing can be stored at 4 degrees Celsius or frozen at -20 degrees Celsius or -80 degrees Celsius for long periods, though freezing may slightly reduce albumin levels. Initial screening often uses test strips designed for albumin detection. However, if the result is positive, it's important to confirm it with a quantitative lab test. Automated strip readers, which measure albumin concentration, provide more reliable results than manual assessments. Quantitative tests for albuminuria include immunochemistry methods like RAA, ELISA, and immunoturbidimetry. Immunoturbidimetry is often considered the standard due to its reliability. The ADA recommends that type 2 diabetes patients undergo albuminuria testing at diagnosis and that type 1 diabetes patients be tested after 5 years of the disease. For negative results, annual retesting is advised. When albuminuria results are positive, treatment with ACE inhibitors can help slow the progression of nephropathy. Regular monitoring of albuminuria is key to tracking the effectiveness of treatment. For patients on ACE inhibitors, ACR values generally remain stable, but untreated patients could see an annual increase of 10 to 30%. Factors like body size, posture, and activity level can also impact ACR values, so early morning samples are usually optimal.